Welcome to the Partnering with Firefighters to Prevent Hospital Readmission webinar. My name is Alex, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Janelle Shearer. Janelle Shearer, you may begin.
Thank you. Hello, everybody. This is Janelle from Stratus Health in Minnesota. I'm with the Lake Superior Quality Innovation Network, and I would like to welcome you to the webinar today. This webinar is intended for organizations working with quality innovation networks in quite a few states, and I'm going to list them: Alaska, Colorado, Hawaii, Illinois, Iowa, Kansas, Michigan, Minnesota, Montana, Nebraska, Nevada, New Mexico, North Dakota, Oregon, South Dakota, Utah, Wisconsin, and Wyoming. So welcome, everybody. Even though all the participant lines are on mute now, please feel free to use the chat feature if you have comments or questions during the presentation. And one thing we would be interested in is if you are working with community paramedics or firefighters in your own communities, we would like to know that, so put that in the chat. Our objectives for the session are to describe an innovative approach to preventing readmissions using firefighters to conduct post-discharge firefighter visits, to discuss data and outcomes from the Hospital Firefighter Partnership, and to identify how the firefighter visit addresses the triple aim and enhances patient and community resilience. Our presenter today is Ben Anderson. Ben is the Manager of Integration at Park Nicollet Methodist Hospital in St. Louis Park, Minnesota. He has been with Park Nicollet Methodist Hospital since 2014 as Manager of Care Integration. Previous clinical nursing experience includes working on telemetry, critical care, medical, surgical, and emergency departments. His previous management experience with working within the hospitalist department, IT nursing, and cardiac cath lab departments. He has a BSN from Winona State University and is a Lean Certified Quality Improvement Specialist. Ben's special interests are in utilization review, transitions of care planning, and clinical documentation improvement. Thank you so much, Ben, for sharing your approach today, and I'll turn the presentation over to you.
Wonderful. Thank you very much, Janelle. And thank you for everybody that joined the call this afternoon. So as Janelle mentioned, I manage our care integration team here at Methodist Hospital, which includes all of our complex transition planners, our social workers, care coordinator, RNs, and it's those groups that are most intimately involved with this firefighter program. St. Louis Park is a first-ring suburb of Minneapolis, so we have a little bit of a suburban feel as well as a little bit of an inner city feel, so it's kind of nice combo. But certainly going to be talking about our firefighter visit program. This program has been going now for just over 2 years. Most of that time has been with 5 different area fire departments, one of them being Minneapolis. Right now, Minneapolis is on hold for some reasons I won't entirely get into, but we do anticipate they'll be back on our program sometime in the next few months. And currently we've got Eden Prairie, St. Louis Park, Minnetonka, and Hopkins as part of this program. So what are really some of our key goals for the program? It's really to reduce readmissions. We were involved with the ICSW and Stratus RARE campaign a few years ago, and one of the main tenets of that program was using the Eric Coleman 4 pillars to prevent readmissions. Those 4 pillars are really, when a patient comes back, the big reasons are they were unaware of what red flags, what to watch out for when they left the hospital, when to call for questions. They were confused about medication changes. They had inadequate resources after leaving the hospital, and they had a general misunderstanding of specific orders or therapies from specialty doctors, providers, what have you. Any of those things or a combination of the 4 typically result in a readmission. Some other key aspects, patients are most at risk for readmission within the first 24 hours post-discharge. What we like to call a difference between is an early admitter versus a late readmitter. Early readmitters we typically define in what some of the latest research says those patients that come back within the first 8 days of being discharged from the hospital often are coming back for more clinical reasons or coordination of care. The idea then of late readmitters is more after 8 to 30 days, or maybe it's more social determinants of health and inadequate resources at home. This particular project and intervention was really looking at those early readmitters, particularly those that bounce back relatively quickly, within a day or two. But nearly 1 in 5 Medicare patients that are readmitted, nearly 1 in 5 patients are readmitted after discharge from a hospital. Certainly a lot of opportunity there. So really the question is, why would we use fire departments? What role do they have in readmissions? Was there a fire? Well, no. But back in early 2014, St. Louis Park Fire Department, right in our community here, contacted us and they said, did you realize that 70% of our calls now are medically related, our 911 calls? So we'll send out a fire engine, a truck, a full crew to a patient that maybe was unsure of their discharge plan. Maybe they have something clinical going on that needs emergency medical team, but oftentimes not. And maybe just they're unsure or don't have adequate resources at home. And so they asked us, they said, maybe could you just give us a heads up when these patients are leaving? And then we don't have to go lights and sirens. We can just maybe go check on them or keep a heads up on them. And what we said is maybe there's an opportunity here to be a little bit more intentional about communicating to our area fire departments when some of these patients are going home, and could we perhaps organize a visit with the fire department upon discharge. Another thing that's worth mentioning, that in terms of fire departments, at least in Minnesota, they are only compensated for that 911 call if there is a patient return to the hospital. So they may be with the patient for 20 minutes, half hour, or more, working with that patient and making sure that they're okay. And if they leave and are successful and don't end up having to bring the patient back to the hospital, they are not compensated for any of that care. So we kept that in mind in trying to build this program. So our plan was really wanted to have more expansive follow-up after the hospital, connect available resources, particularly those that are already in the community, to ultimately prevent readmission. National Institute of Health suggests that better follow-up post-hospitalization could prevent up to 75% of readmissions. All of us know that we can't prevent all of them. Certainly a patient may leave the hospital after having pneumonia and gets in a motor vehicle accident and is back with a broken leg or something. We can't always prevent those, but certainly we want to make sure that the patients aren't coming back for preventable reasons. Fire departments are in a very unique skill set in meeting with patients in the home setting and connecting them with resources that are already in the community. For years, it's not that they've had the capacity to serially manage and view these patients, even though there's some patients that may, or community members that may utilize fire department resources habitually. They are very good at putting that person in touch with what some of those resources are. Food shelves, social services, church services, parish nurses, primary care, what have you. In terms of process, what's really the first step? Well, obviously the patient is admitted to Methodist Hospital. And we look at, does this patient meet the criteria for our visit? Right now our inclusion criteria is that the patient certainly needs to be at Methodist Hospital. They could be in any age, any clinical situation. They would be going to one of the 4 cities, as I mentioned earlier, Eden Prairie, Minnetonka, Hopkins, or St. Louis Park. And they are not going to a transitional care unit or being enrolled in hospice. But if it is a home care patient, if it's going to home without services, someone going to an assisted living, in any of these communities, any ages, they are eligible for that one-time visit. Next step is, after we've ruled the patient in for inclusion criteria, we notify The care team vet patient's eligibility, we do this through our our electronic medical record. We also will do it as our staff, our care integration staff round with hospitalists throughout the hospital and to bedside nurses. Our goal is to really then get that message out to the patient through several different avenues to help encourage the program and let the patient know that it is an option for them. Next step is we actually have a firefighter coordinator. This is a person that works within my department, and she has a lot of different roles, but one of them is that she will visit these possible patients up on the acute nursing units, tell them a little bit about the program, and seek their consent for the visit upon their discharge. She knows the program inside and out, can answer any questions that they may have. She will also show them a video, or we've got a closed circuit loop of a video explaining the program that the patient can watch, really at their leisure. She may gather a consent right at that point in time, or may come back closer to discharge to see if the patient is willing to consent to that visit. This is a flyer that we have that explains the ins and outs of the program, how do they sign up, what do they do, what happens with that visit. So at this point, let's say we've got the patient, they've engaged, they say, yes, I want it. Well, what's our engagement rate? This has actually been one of the biggest struggles with the program. For whatever reason, our patients, family members, community members haven't always been the most receptive to this visit. Prior to the program, we did some research that showed us that firefighters are the most trusted community service worker. Usually people don't have any problems coming into their home. They know they're there to help them. They are very well trusted. However, we think that there is a social barrier to having any care provider, whoever it is, come into their home after a visit. So even though we're offering a free service, we're doing it with the best of intentions. We may even be giving the patient a free smoke alarm and carbon monoxide detector out of the deal. They don't always agree. So our engagement rate in terms of attempted consents to completed consents has been hovering in the 20 to 30% range most of the program. You'll see on this graph there was a spike in a spike in engagement back in late 2014. Well, that was because we actually didn't have anybody solely assigned to obtaining consents, and so we were only focusing on those patients that we thought would really agree to it. So, our engagement rate went up. Since then, we've got a dedicated person obtaining these consents at least 5 days a week, but our overall engagement rate has not necessarily come up. So we're looking for better ideas in terms of how to get patients really to see the value in this and understand that they really could benefit and they need it. I like to tell my staff is that we want to put a healthy amount of fear into patients and their families that they are in a precarious situation after the hospital. They're not going to be 100% ready to return, to their previous lifestyle, and this is one stepping stone to get them there. This is what our consent looks like. It's written in layman's terms, but it does allow the patient to sign off so that we can essentially send protected health information on to the area fire departments. We send them a copy of our after visit summary, which is essentially a summary of the patient's stay in the hospital as well as our aftercare plan and a list of the medications the patient is on. So the fire department has that. Upon the completion of the visit, the fire departments actually shred any protected health information that they've been sent. How do we get that information then to the fire department? It's a little bit old school. We assemble a paper packet and send that on to each of the respective fire departments. So if we have 2 visits tomorrow to St. Louis Park, we'll send them a packet for each patient and include a copy of the phase sheet. So they've got the demographic information for that patient, the consent form, and then the after-visit summary. So the summary of the patient's stay and what their aftercare plans are. We'll also provide them information such as, was this a high-risk for readmission patient, or did we deem a high-risk for readmission? Do they need an interpreter? So if it's Russian, Somali, Hmong, the fire departments have an opportunity to get that interpreter in place. And is there a same-day visit requested as well? If we're sending a patient home earlier in the day and there's potential to have a same-day visit later that day for a higher risk patient, we're able to do that. But usually the presumption is it's a next day visit. What's next? Patient does transition to home. We let the patient know that the fire department will be calling the day after discharge, setting up that visit. They typically call mid-morning, typically call between 8 and 10 a.m. to set up that visit sometime between 9 and 1 p.m. So I said that visit then takes place most commonly between 9 and 1 p.m. What happens with it? What do the fire departments do? Well, they assess vital signs, so they'll go in, meet with the patient, see how they're doing, do a general overview assessment. We'll do essentially an EMT firefighter assessment, so blood pressure, heart rate, respiratory rate, full set of vital signs. We'll review the after-visit summary with that patient. They will also do what's called a PEAK assessment. This is a safety assessment of the home environment. Things like, how tidy is the space? Is the electricity in order? Is there any evidence of hoarding? Area throw rugs? Any type of security concerns that they can go over with that patient, and will help address them right then and there. If the patient does need things like a new smoke alarm, CO detectors, they will provide them for them. They'll also remove area throw rugs, any hazardous materials that may be harmful to the patient. If the patient consents, they'll also let us look, to their kitchen. If they don't have adequate food supplies, the fire department will contact local food shelves, and our Park Nicollet Foundation has actually sponsored the area food shelf, so they will deliver food to that patient if needed, if that's considered or found to be a barrier. In terms of more of the clinical overview for that patient, like I said, they will review all of the aftercare instructions on the AVS. They will also review medications. They won't provide medication instructions, but at least verify that the patient is aware of what medications they're taking. They understand why they're taking them, and if they have questions, they will route that question to primary care provider. Throughout the visit, they will be completing a checklist, the documentation form. This form is eventually sent back to us at Methodist, so we will record all responses and document it for them. But if they take any specific actions with that patient, such as contacting our primary care team, any adult protection reports, any contacts to a home care agency or other agency referral, they will record that. We have given the area fire departments essentially a hotline into our primary care provider call center, so that if they need to get a patient in for a same-day appointment with a their primary care physician, or have a question of a triage nurse, they don't have to wait on hold. They can also call directly into our network of 28 clinics. So certainly, what's the significance of the firefighter visit? They provide a face-to-face visit to support transitions to home in collaboration with home care and the clinic. They are not meant to replace any services. This is more of a supplement and adjunct service. And the more that we can bridge that gap between the hospital and the next stage of care is really what we want to do. Supports the goal of maintaining and improving self-management skills. We know that we can't do everything for the patient, so one of our goals is to really get the patient to understand what situation they're in, better understand what they need to know, so that they need to maintain their own medication list. They need to understand, why they're taking this, what's the next stage in their care, Let's say they're seeing primary care on Thursday and they're back with cardiologist on Tuesday. We can help reinforce that message. An additional tool we use is a flyer that was created by the Robert Wood Johnson Foundation several years ago, which is really to promote that self-management for patients so that it's not, a primary care provider, a nurse, a daughter, a spouse that is walking them through that, but they really are a little bit more self-sufficient. We have the ability to escalate services with home care or primary care if needed. So those pieces are already in place, and it works very well. A frequent question from home care agencies is this, well, are you just trying to replace home care? Absolutely not. This is completely meant as an adjunct. We have our own home care business within Park Nicollet, and their leadership has been involved with this program every step of the way. However, one of their challenges, particularly for those high-risk patients, is to get out to that patient in a timely manner so that we can potentially prevent a readmission. They can oftentimes get out, our fire department can oftentimes get out and see that patient before home care even has a chance to do a full admission. So home care may take 48 hours. This is within that first 24. Provides a variety of community resources that we, in the hospital are aware of, but as well as community resources that fire departments have been using for years and years, such as, food shelters I mentioned, parish nursing, lots of different other things that may be available. And any patient, any age may need help with transitional support. We've done visits from, I believe, a few weeks up to 103 years old. So really any patient can benefit. So some demographics, and this data, I would say, my data is not completely up to date. You saw the earlier slide, which was back in February. We still are a relatively small program, and so we're doing our data on our own. But this is as of late April. We're up over 800 visits at this point in time, but our youngest was 3 months. Our oldest was 102 years old. Average age for a client is 68. It's about 40% males, 60% females. We have a little bit easier time, for whatever reason, consenting our females. In totals, we've done 158 high-risk for readmission patients and 766 total visits, but I know we're well over 800 by this point in time. Some more data. Average, so how long does it take to schedule? It's about 1.3 calls for the fire departments to set these visits up. An average visit takes 23 minutes in the patient's home. Typical range is 9 a.m. to 8 p.m. And actually, I think it's, we'll do them from 9 a.m. to 8 p.m. An average visit takes place between 11 and 1. Our PEAT score, and these scores are, it's not necessarily translatable to different municipalities. Each one of our fire department they do a PEAT score a little bit differently. Whether it's a suburban household, whether it's an inner city household, but essentially it means our PEAT scores are pretty good. Our patients are typically living in fairly safe environments. We don't have huge concerns there, but this is an opportunity to get into their home and help them with that. Some of the overall outcomes, again, these need updating, but one of the most frequent things that we provide a patient is installing smoke alarms. It's not shown on this slide, but that was the 126 item. Also, patients will need just a welfare check. So if we go into their home and they're not there, we'll knock on the door, check with neighbors, call emergency contacts to make sure that things are okay. And perhaps they're just at the pharmacy or out for a cup of coffee or something else, but we will ensure that the patient is okay if we were set up for a visit and have not heard from them. Other things, we've connected with the patient with their primary care team about 30 times, initiated 911 only 11, and referred to a food shelf about 25 times. Usual age of a patient is 68 years, as I mentioned. Some of our quality data, it shows that 99% of our patients that have had a visit would recommend it to others. And I would say that the one patient that disagreed with that comment, she later wrote in the margin of her survey that oh, this was a great program, we loved it, I'd love to have it again. So really it's 100%. Pretty much anybody who's had a visit has said, this is great, I'd recommend it to others. In terms of what the patients found most helpful, they said the appointment review was ranked as the most helpful. So when is their primary care visit, maybe when are they meeting with a cardiologist or an oncologist or what have you. So that's certainly something to take back to each of your sites to make sure those patients are aware of the next time we will encounter them, with their care centers. Impact on readmissions. We have seen a 3.2% lower readmission rate when a patient has a firefighter visit to when they do not. Now that may not seem like a lot, but in the world of readmissions, which has basically been my life at work for the last several years, that's a very big improvement. We've done a lot of very big efforts that have shown to have little to no impact on readmission, so to have something have a 3.2 is significant. For males, the readmission rate is even a little bit better. It was about 14.51% lower. And take what you will with that. Perhaps it means that, males are a little bit more responsive to this style than females. I don't know, but we did see a lower readmission rate with that group. The age groups that we found to be the most benefiting of this project or this program are 50 to 60-year-olds and 81 to 90-year-olds with an over 10% readmission rate drop. Interestingly, as I mentioned, males had a 14.5% lower. Women who had a firefighter visit actually had a higher readmission rate at 4.57%. We're not entirely sure of the reason for that, but it could be that us asking repetitive questions actually got the patient thinking about, okay, maybe I do need to go back perhaps earlier than I would have before. But this is still a very small sample size in terms of data. As I mentioned, just for right around 800 visits. So we do know that our data will change over time as we get more patients agreeing to the visit. With that, I'd like to open up to questions.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. And we are currently standing by for questions. And it looks like our first question comes from Fran Ria from Molina Healthcare. Fran, please go ahead.
Hi. I missed the first few minutes where you did the introduction and heard you say about reimbursement. Firefighters only get reimbursed for a run where they admit somebody to the hospital. So I missed the part how they're getting reimbursed for all these visits. And I think the program is wonderful adaptation of the Coleman model, by the way.
Oh, thank you. So, and I'm calling from a Minnesota perspective, so certainly I think it's different state to state and perhaps even municipality to municipality. But in Minnesota, our 911 services, at least the community-run ones, are only reimbursed for that visit from the state if there's a 911 transfer, or reimbursed by commercial insurance if there's that ultimate transfer into an acute hospital. So they need to provide those services. If someone calls 911, they may go in, do a home safety check, evaluate the patient, do a full EMT assessment, find out that this patient's okay, they don't need to go in, but all those services then are provided free of charge. So one of our goals was to prevent those bounce backs, but so that the 911 call never had to happen. We can reduce the amount of resources going out to these homes with the setup visit. We don't need to necessarily send a full engine, an ambulance, a black and white, and an SUV to these homes. We may just be able to send an SUV with a couple of fire department members to meet with that patient.
Okay, thank you very much.
And I guess I'll also break into that. Reimbursement certainly is one of our biggest challenges right now. We think that there's certainly enough value in these to be able to be covered, either in the short term on a fee-for-service basis, but we think in long term we'd like to cover them more from a population health basis, eliminate the administrative burden of saying, okay, each visit gets $25, $50, $75, whatever it may be, and have it be more of a ongoing expense. The way that our area fire departments and we as a healthcare provider have done it so far is really just through general operational expenses. We haven't added any positions, we haven't added any infrastructure, and that's also a beauty of the program is we're using existing infrastructure. We're using area fire departments that are staffed 24/7 and that have fully staffed fire departments, so it's not necessarily something that's going to work at 100% volunteer fire department, but they've got capacity. They've got fire departments that have people ready on call that are ready to go do these visits. And if there's not a fire going on, we still have that capacity. So we're utilizing that existing capacity, existing funds, but we know that we'll come to a head where we need to have a new revenue stream.
Thank you.
And our next question comes from Tana Hedstrom from Wyoming Medical Center. Tana, please go ahead. Hi, Tana Hedstrom online.
Here, sorry about that. Took us a little while to unmute. What is the PEAT score? I'm not familiar with that acronym.
I may have to go back to one of my notes. I've been calling it PEAT for so long, I think I forgot.
Well, I don't mean what it stands for, but what you're assessing.
Sure. Physical Environment Assessments Tool. It is essentially it's a tool used by area fire departments, and it's not necessarily limited to a fire department, but they're really doing an environmental assessment of that patient's their dwelling. Is it clean? Do they live alone or with others? Is there any signs of abuse or neglect? Are there any safety hazards around, such as unsafe wiring, lack of plumbing, holes in the floor, black mold, things of that nature that we would want to address either directly with the patient or perhaps other resources. There may be an adult protection report that comes out of that PEAT score, or there may be just immediate interventions that the fire department can make right then and there. As I mentioned, getting them new smoke alarms, carbon monoxide detectors.
So what would be a PEAT score of somebody's home that was, pristine, adequate resources, no issues at all? Would it be 100 or would it be 0 or what?
It would be actually 34 is the top score, I believe. But what our fire departments have told us is that the PEAT score is somewhat subjective. So it's not that you could take a PEAT score done in Hopkins, Minnesota and compare it to a PEAT score in Cheyenne, Wyoming. It's really independent to that particular fire department and how they score it.
The higher the number, the better off the patient is, basically, in terms of safety.
In terms of at least physical environment, yes.
Yeah, thank you.
And our next question comes from Natasha Green from Stanford Health. Natasha, please go ahead.
Hi, my question is pertaining to the eligibility for the patients. Can you go a little bit more in depth on how you select these patients while they're in the hospital setting?
Sure. We actually we built a report within our electronic medical record that will generate a list of patients that are in our 5 respective cities. We then have one of our staff members quickly review that and see what patients meet the criteria. But the criteria are very simple. Is the patient going anywhere but a TCU or to hospice? And are they in one of those cities? So we've kept it very simple. Another way that we can get referrals is from our inpatient care coordinators and social workers. If they see a patient that we perhaps missed, says, hey, here's another patient that they don't live in one of these cities, but they're going home to their son or daughter that does happen to live in one of those cities, they're also eligible for a visit. So, but the inclusion criteria are very simple. Do they live in those cities, and are they going to anywhere but PCU or hospice?
Great, thank you.
And our next question comes from Kathy Ingebrett from Blue Cross Blue Shield. Kathy, please go ahead. And if Kathy Ingebrett is online, your line is open.
This is Kathy. Are the firefighters certified as community paramedics?
No, our program, it is a little bit different than perhaps some of the community paramedic programs that you may have heard of. We are staffed with EMT firefighters, and it is really a one-time visit. We are slightly different than the community paramedic program, some of which may follow that patient, serially over several weeks or months. This is a one-time visit after discharge.
After discharge. Okay, thank you.
Mm-hmm.
And this is just another reminder, if you do have a question, please press star, then 1 on your touch-tone phone. And if you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, that's star, then 1 on your touch-tone phone. And our next question comes from Fran Rea from Molina Healthcare. Fran, please go ahead.
Thank you. I wanted to know if there is a transcript available along with the slides. I have slides, because there was a lot of information that Ben gave. And my second question, and I may have missed it, how you engage the fire departments in this model. I'm in Metro Detroit, so.
Mm-hmm. So they actually, in terms of your first question, I do believe this is being recorded. I'll defer to my Stratus colleagues as far as how you get it, but I believe this is recorded, so you'll be able to watch it again later. In terms of your second question, since St. Louis Park actually reached out to us first, that step was quite easy because they said, hey, we really need to do something differently. What we've also learned in working with fire departments is that they are quite frankly, they are much more coordinated and organized than we as healthcare providers are. All fire departments throughout the country have very robust, and I can't say all, but as far as I know, every fire department throughout the country has very robust mutual aid agreements so that they can call upon neighboring fire departments should they need additional assistance. If it's a really big fire, perhaps, that is taxing their resources, they can pull in outside communities for help. And we built our program around that premise. So theoretically, if we had, let's say we normally have 1 to 2 visits a day, and all of a sudden we had 50 tomorrow, they could pull it off. They could pull in enough area fire departments, if they asked, to get those visits done. When we call any of our area fire departments, they are very well aware of what's going on at the different communities. They know the fire chiefs, the assistant chiefs, and they work very closely with each other because of those existing mutual aid agreements. I would assume in urban Detroit, certainly my guess is there is a Detroit proper fire department and also many different surrounding suburban fire departments. My assumption is that they work together very closely. Chiefs know chiefs, and if one department was very interested in it, they'd probably have an easy time recruiting others to get buy-in. So, not sure if that quite answers your question, but certainly you can elaborate if needed.
No, thank you very much.
Mm-hmm.
And Mr. Anderson, that looks like all the questions we have at this time.
Okay.
Hi, this is Janelle. I'm managing the chat, and we have a few questions on the chat. I will also put where the recording will be posted and we will also get it out to each of the QINs of the states that were mentioned earlier on the call. But here's a question, Jen. It's from Leah Brandis. She says, please clarify how this program complements home health. What are the different roles of each? I assume your program is not in place of home health. And then I'm going to add my question to that. Did you get pushback from the home health agency when you first started this program?
We didn't get, there was some, in terms of the home health, I think any pushback was resolved very quickly. One thing is that this is a one-time visit. This is not a serial visit. It is also not limited to traditionally, Medicare eligible home care patients. It's available to any patient. But our goal is to really get to that patient within 24 hours so that they understand what their transition plan is. If they have any outstanding questions, we then relay those questions to the most appropriate care provider, whether that is primary care, the home care provider that likely has not seen that patient quite yet or maybe will be coming later that day, or even back to the hospital if there's just some confusing questions about what the plan was. We are done at that point, and the home care is able to manage that patient however they need to. But hopefully, if we sent the patient into a unsafe environment, if we identified anything before the home care agency could reach that patient, we hopefully avoided, a scary situation for the home care company as well. There's these patients that we recommend a skilled facility, whether it's a SNF or a TCU post-discharge. Either they're unwilling to really work with that plan or there's financial barriers, and so then we use oftentimes home care is somewhat of an in-between. This will help, again, bridge that gap for that high-risk patient, as well as perhaps encourage the use of a higher level of care for that patient if home care is inadequate. So.
Okay, here's another one from Leah. What happens if there's a fire in the community when these appointments are happening? So do they postpone it, or what do they do?
So fires are going to certainly would take precedence, but they will be able to oftentimes rearrange their schedules and their resources to still complete the visit that day. But as I mentioned with an earlier question, we have very robust mutual aid agreements with these 4 communities, so that if St. Louis Park can't do a visit right now because they've got a fire in their community, they can immediately call upon Minnetonka, and Minnetonka will come do the visit. Or Minnetonka goes and does the fire while St. Louis Park does the visit. So they've got resources they can very easily flex up and down depending on need, and that's something that I would willingly admit they are much better at than we are in healthcare.
Okay, great. Another one is, do you give a specific time for the appointment or a wide time frame to expect them?
We let the patient know that the fire department will call them in the morning. Believe it's between 9 and 11 a.m. to set up the appointment. And then they give, I believe, about an hour time frame that they'll be there. So it's not quite cable guy times. We try to make them a little bit better than that. But there's a little bit of push. I believe it's an hour time frame.
Okay, great. Let's see, I believe you answered this already. What is the PEAT score? And then, let's see. I'm not sure if you need to repeat this or not, but I think you may have addressed it. I am still not clear how the program is paid when they do a follow-up visit from discharge.
Yeah, and the short answer is right now the visit is not paid. We're using operational resources that are already in place. Fire department's using their budgets, and us as a healthcare provider using ours.
Okay, great.
We do have some funding from our nonprofit foundation, so there are some charitable offerings that go towards this, but currently it is unfunded.
Okay. That's all in the chat right now. I'll have Alex check to see if there are any others on the phone with questions.
Yes, no questions at this time, but I will offer one last reminder. If you do have a question, please press star, then 1 on your touchtone phone. Again, that's star, then 1 on your touchtone phone.
Okay, and while we're waiting, we have more questions in the room here, Ben. One question is, have you considered giving the firefighters EMR read-only access, or is that not even necessary?
Great question. Glad you brought it up. So our EMR here is Epic. Epic has a system called Epic CareLink, which is a web-based view-only version of Epic, and we would love to get that out to all of our area fire departments and prevent this, antiquated faxing of information, make it more secure, more streamlined, easier. But because of protected health information, because of legal requirements, and a lot of liability in terms of sharing information back and forth, we've not been able to tackle that quite yet. But I think we will sometime within the next year, so that all of our area fire departments will have access, that read-only access to the patients that we are sending them.
Okay, great. You mentioned that people in the 50 to 60-year-old was an age range that really benefited most from the program.
Mm-hmm.
And so I'm curious about those people at that age, in that age group. Are they folks with a certain payer source or a lot of chronic disability, or is there anything you could summarize about that age group that maybe...
My theory with the 50 to 60 age range, and again, this is a personal theory, but it's drawn off, several different projects we've done, is that the 50 to 60 age range is those folks that they're going home in a precarious situation, but they don't really know it yet. So they've got plenty of resources. They're very able-bodied for the most part. They've got community resources. They've got usually able-bodied family and friends, but they're not quite sure of what they're getting into. And when things go wrong, they go wrong quickly and they bounce back. For the later age range, the 80 to 90, they may know that they're going into somewhat of a difficult situation, a bit of a predicament, but they don't necessarily have all the same resources or physical wherewithal to deal with them, and so they bounce back. So it's we need to take a little bit different approach with each age range in terms of what interventions we put in place. But the nice part about this program is it's not limited to any particular age, and we think it could benefit all those age ranges, because every patient can benefit from a little bit better understanding of their after visit instructions, a little bit better review of their medications and their follow-up appointments, and a little bit more validation that they have community and personal supports in place.
All right. Actually, two more since we still have time. One has to do with the triple aim and the role of emergency systems. Mm-hmm. I've heard that they are written in the Affordable Care Act, and I'm just curious on what it states their role is.
Mm-hmm. So, in terms of cost, as mentioned a few times, right now we don't have a revenue source for the visit, but in cost we are hoping to reduce readmissions. An estimate I've seen from Medicare is that each prevented readmission saves Medicare at least $5,000. So any one we pick off, that's $5,000 at least for a commercial plan patient or a patient with severe outcomes because of that readmission. Those costs go up. We haven't actually added any overall cost to the healthcare system as part of this visit because we are using existing firefighter infrastructure. In terms of patient experience, as I mentioned, 100% almost of these patients think their visit was great and they found value with it and would recommend it to others. And then finally, the outcomes, again, reducing readmissions, getting patients out of the hospital, and reducing overall healthcare costs.
Thank you. I noticed in the chat when we asked earlier on if folks use either had a community paramedic or firefighter in their community. Christy Woody responded that in St. Paul, Minnesota, they're working with 2 community paramedics. And I'm wondering if, Kristen, if you're on the line yet, if you are able to speak to those programs at all. Or is anyone else working in a similar program that you could just share a little bit about what your program is like? Okay, well, I'll check one more time with you, Alex, to see if there are any other people in the queue for questions.
No, it doesn't look like we have any questions at this time.
Okay. Well, it looks like we've answered all the questions from the phone and in on the chat, so I would just like to, first of all, thank you, Ben, for sharing about your program with those of us in all these states that we mentioned. And thank you to everybody who participated in the webinar. When you close out the webinar, the evaluation will come up for you to complete, and it will be posted on the Lake Superior Quality Innovation Network site. We will also get the recording sent out to the different QUINs, so you can contact the QUIN in your state for that. So thanks, everybody. This concludes the webinar, and have a great rest of the afternoon.
Thank you.